Welcome to our surgical weight loss seminar. I'm Dr. Vincent Lusko, and along with Dr. John Olsofka, we'll be presenting information about obesity, the lap band procedure, and our program's philosophy and aftercare program. I developed a strong passion for weight loss surgery back in 2001 when I helped assist on the first lap band in Kentucky. It was at that time that I realized there was a much simpler and safer alternative to the more radical stapling procedures that were available at that time. Dr. Olsofka and myself, we began this program in 2003 at St. Mary's and Elizabeth Hospital, and since that time we've performed 4,000 lap band procedures. We've been recognized as a center of excellence and also have received numerous distinctions and recognitions. More importantly though, we've helped transform the lives of over 4,000 patients in helping them lose weight and become healthier. So what is obesity? We hear that term all the time. As physicians, we look at that as a chronic, life-threatening disease. When you hear the word bariatric surgery, all we're referring to at that time is weight loss surgery. When we look at the causes of obesity, it's a multifactorial process. It's not just one or two things. We look at a person's metabolism and their genetics. We also look at environmental and cultural processes. And there's also numerous side effects from medications that people take that cause weight gain. In the old days, you had these little tiny Coke bottles, and now there's ballooned up to these gigantic, 16, 24-ounce bottles, and you even see the 64 ounces at the gas stations. Additionally, in the old days when you went to the movies, you had a little popcorn box. Now it's ballooned up to this giant tub that has free refills. So the new definition of normal has changed in our society. The other issues is that, as we mentioned just previously, is a person's metabolism. And the problem with the metabolism is that you can have two kids that grow up kind of in similar environments and eat the same things, and one will grow up and be tall and lean, and the other will grow up to be overweight. This is the BMI charts that we use to determine how obese or overweight somebody is. And it's typically below this black line where someone is a candidate for weight loss surgery, although there's been some new FDA guidelines that allow people with BMIs of 30 to 35 to be candidates for this as well. But this is simply calculated by taking one's height and their weight and punching it into a formula. As this slide shows the different categories of BMIs, a normal BMI is defined as between 18 and 25. In the category of a BMI of 30 and above, you see the categories of obese, severe obesity, and morbid obesity. These are the patients that typically benefit from weight loss surgery. And when you see that word morbid obesity, that has a connotation of a decrease in life expectancy. So as we've seen in our society, obesity has become an epidemic. Recent studies have found that 1 in 3 people in the United States is obese. And in the past 20 years, these numbers have doubled. When we began giving these talks over 10 years ago, it was 20% of the United States were overweight. We're also seeing an alarming number of children that are becoming overweight. And this is mostly due to decreased time for physical activity and worsening food choices in the cafeteria. But unfortunately, about 75% of these obese children go on to become morbidly obese adults. Also, to put this epidemic in perspective, there were 400,000 premature deaths last year noted due to obesity. And what we're seeing is that the number of deaths from smoking last year was 400,000, which is the same amount as the number of deaths from obesity. And that number seems to be going down since fewer people are smoking. And to put that in perspective with the two most common cancers that we see, both colon and breast, there were 90,000 deaths from that last year. As this slide shows, there are many health problems associated with obesity. Some of the common ones we hear about are diabetes and high blood pressure, as well as reflux, sleep apnea, and problems with mobility such as arthritis. The other issues that we encounter is fertility issues in women, as well as certain cancers such as colon cancer, breast cancer, and uterine cancer. Most patients who are at the point of considering weight loss surgery have tried multiple attempts at weight loss in the past, and these have mostly included diet and exercise, working with their physicians, taking appetite suppressants, and some more extreme measures such as hypnosis and jaw wiring. This cartoon, I think, reflects some of the frustration that our patients will have when they come into their physician's office and they get told to just try the Atkins diet or to exercise more. But this is a cartoon that one of my patients gave me. It's a very simple diet. You can eat anything you want as long as you chew each bite 3,000 times. The problem is that most diet and weight loss aids rarely work in helping us reach the goal of long-term weight loss. So why would someone consider surgery? Well, only 3 to 5% of people who attempt weight loss are successful long-term. Additionally, the National Institutes of Health states that surgery is the most effective and the only method which results in significant weight loss long-term. And here recently, the American Diabetes Association, which is an association mostly of family practitioners, endocrinologists, and internists, these are not surgeons, but they've recommended that anybody with a BMI of over 35 and type 2 diabetes should be evaluated for bariatric consultation. For the next series of slides, I'd like to discuss different treatment options that involve surgery to help people lose weight. And in the old days, there were some purely malabsorptive procedures, which we're not going to get into, but they basically bypassed the majority of the intestinal tract. Then back in the 80s, there was a restrictive procedure that was fairly commonly done called a vertical banded gastroplasty, and that was the beginning of the restrictive procedures. And that basically reduced the amount of food that you could eat at one time. And then with the advent of the gastric bypass procedure, that was both a combined procedure that provided both restriction and malabsorption. So next we're going to discuss some of the current treatments for obesity that involve surgery. On this slide you see the lap band and the gastric sleeve. We're not going to spend much time talking about the gastric bypass because it's not commonly done. The gastric sleeve we'll mention here involves amputation of about 85% of your stomach. So with the gastric sleeve, it's becoming a very common procedure across the United States. We are trained to perform this procedure. However, we have some concerns about the safety and long-term outcomes that we've seen so far. First of all, there's not much debate that a well-done sleeve provides good initial weight loss, almost as much as a gastric bypass. The major issue is that over time, that small tunnel of stomach that's created can stretch back out, and that leads to patients becoming hungrier and being able to eat more food at one setting. A lot of the 5-year data shows that a lot of these patients have gained most of their weight back. This operation was initially designed to be part of a 2-stage operation where the sleeve is done initially, but then once a patient started to gain weight, there was an intestinal bypass procedure recommended afterwards. Unfortunately, that's not how this procedure is promoted these days. My other concern with the sleeve is that there are risks from leaks from the long staple line, which can lead to lengthy ICU stays and require multiple reoperations. Other issues include worsening reflux after the sleeve, requiring extra acid medications. The rest of the talk we'll spend discussing the lap band system. It has multiple advantages over the other stapling procedures. It's by far the least invasive approach. It doesn't require any stomach stapling or cutting or intestinal rerouting. It's also completely adjustable, which I'll discuss more in a moment. It also has the lowest operative complication rate and a very low mortality rate and a very low malnutrition risk. And as you can see from this video, there's a soft silicone band that's put around the very top part of the stomach, and it creates a pouch about the size of a golf ball. And the balloon that's on the inner portion of the band allows us to control how quickly that pouch empties. The tighter the band is, the slower the pouch is going to empty, and the more open it is, the faster it's going to empty. Some of the disadvantages with the lap band are that the weight loss is not quite as fast as with the gastric bypass or with the gastric sleeve. And, to some people, they look at that as a negative. I've always taken a different approach. I think that, most of the time, patients didn't gain this weight overnight, and it's really not safe to lose it overnight either. Also, with a more gradual weight loss like we see with the lap band, there's fewer plastic surgery procedures that are probably going to be necessary later on because there's not as much loose or saggy skin that you see sometimes with the bypass procedures. Also, the other thing that's super critical with the lap band is that patients have to follow up after the procedure. They can't just have this done and not follow up and get adjustments, or it just won't work. So in summary, there is a band placed around the very top part of the stomach that creates a small pouch that holds less food than what your normal stomach does. This is the part of the stomach that tells your brain to stop eating, that you're full, and that's the mechanism by how this works. The adjustments are fairly simple. They're procedures that take place in the office and take just a couple minutes. We'll talk to the patients every time they come back to the office to determine if they need to have an adjustment or not. One of the things that's special about our aftercare program is that we do the adjustments ourselves. And when I say we, I mean Dr. Olsofka, myself, or Dr. Toyer. And we'll visit with the patients every time they come back. If the patient's eating more food than expected and their weight is plateaued, then we decide to do an adjustment at that time. If they're eating small amounts and losing weight on a consistent basis, that patient typically doesn't need an adjustment. Most patients take about 2 to 3 adjustments to get the band just right, and they'll take somewhere around 5 or 6 adjustments over the lifetime of the band. So they're not going to need an adjustment every time they come back to the office. So up to this point, we've spent most of our time discussing the actual surgery. But really, the important part is after the surgery and the follow-up. And the most important thing about our program is the aftercare. And I think that's where patients are going to find that's why we have such great results with the lap band. When the patients come back, they're going to meet with the physician who did their surgery, and I think that that's really important. You're not farmed out to a nurse practitioner or to a PA. When we meet with those patients, we sit down and we talk with them about their dietary habits and what they're eating and how much weight they've lost, because that's an important factor with the conversation as well. But the thing that's important about the adjustments is that we don't follow a cookie cutter algorithm on how much fluid to put in the band. A lot of programs will put the same amount of fluid in each patient each time they come back. The way we do our adjustments is that they are very customized and tailored for each patient. The way it works is when we see the patients back in the office, we'll talk to them. If we decide that they're eating too much and their weight's plateaued, then we do the adjustment right there at that time. It takes just a couple minutes. We clean the skin off with a little bit of alcohol. We access the port. There's really no discomfort with that. We then have the patient sit up and we give them a glass of water. The band is then over-tightened to where it's basically closed off, and we have the patient take several drinks of water, and after about the 3rd or 4th drink, they'll feel the water pass through. At that point, we know that that's the sweet spot on the band. We then confirm it with another couple drinks, and if the water's going down easy, we know that's right where they need to be. Most patients will take about 2 to 3 adjustments to get their band just right, and most patients will take about 5 to 6 adjustments over the lifetime of the band, so they're not in the office every couple weeks getting a fill. This is really important to get the band tightened just right, because if you don't follow up and don't get an adjustment, it's not going to work. Along with these other visits, we're not only assessing them for how much food they're eating, but we're also trying to give them tips and advice to make other healthy lifestyle changes so that they can be successful long term.
So my name is Dr. John Olsofka, and I'm going to finish the second half of the seminar on the lap band. I may reiterate some of the things that Dr. Lusko said, but I hope that you recognize the passion we have with the lap band surgery and with our program. We talked about how weight loss surgery can change your life. You had better believe it. This is not about a cosmetic procedure. We look at health problems such as diabetes, hypertension, gastroesophageal reflux, sleep apnea. All of these things are intimately associated with being overweight. With the lap band, we are able to decrease all of these comorbidities. You look at someone that loses weight with the lap band, and 100% of them will improve in their type 2 diabetes. In fact, it's been shown that with long-term weight loss, almost 80% will get off medication completely. If you think about what this change is long-term, this can be dramatic as far as your health care is concerned. We look at a couple patients that we have before surgery and current. Now, you can certainly tell with this young lady, her life has been changed long-term. The time frame with this is about 4 or 5 years. But you can see that her whole lifestyle has changed. Her weight's down, her comorbidities are improved, she's dyed her hair, she's having more fun, she's got a new attitude. It is a complete lifestyle change. Look at our next lady here. Basically, she's on multiple medications for some of the things that we mentioned. Diabetes, hypertension, heartburn, all of these things that are associated with morbid obesity. But more importantly, her copayment with these monthly medicines is almost $300. Now, I hate to tell you, but you're not going to get a phone call or an email or a letter from your insurance company that says, we've got great news, we're going to lower your copayment. It's not going to happen. But when you look at this lady's results, this is only 6 months later. She is no longer diabetic, she is no longer hypertensive, she no longer has reflux disease. She has a copayment of $25. The only medication she's still on is allopurinol, and that's for gout. So we don't do real well with gout, but all of these other things are radically changed with long-term weight loss and the lap band. Well, let's look at some history with the lap band. It was developed in Belgium in 1993. It was improved in the United States in 2001. What is that delay? Well, as you know, there is a long process for getting anything approved in the United States. If you look at the heartburn medicines, omeprazole, these were out in Europe 20 years before we got them